My name is Dr. Asma Bloui. I'm going to talk to you about management of COVID-19 patients with chronic disease and nutritional interventions. Critically ill patient with COVID-19. There is a general ICU rules in pandemic, according to the Ministry of Health. Critically ill patients in the emergency department or in the general ward shall be transferred to ICU in an expeditious manner. Patient care in ICU should be led by intensivists in day-to-day management. During the pandemic, Ministry of Health doesn't recommend a 24/7-day-a-week intensive care to the patients. Ministry of Health suggests optimizing ICU nursing resources with nursing patient ratio 1:1 for ventilated or multiple organ failure and 1:2 or 1:3 in severe shortage for other ICU patients according to the local capacity plan. Patient admitted to ICU if the prognosis for recovery and quality of life is acceptable, taken into account factors such as age, comorbidity, prognosis, underlying diagnosis, and treatment modality that can influence survival. ICU triage recommendations. ICU triage decisions are made according to patient condition and the need for critical care monitoring or intervention. Patient to be admitted or discharged strictly on their potential to benefit from ICU care. Some over triage is more acceptable and preferable to under triage. Transfer time of critically ill patient from the emergency department or ward bed to the ICU in less than or equal to 1 hour from the time of consultation if a bed is available. If the ICU bed is unavailable, ICU physicians continue to deliver care for critically care patients in the emergency department or the ward with the help of the primary team. The most senior ICU covering physician is responsible for making ICU triage decisions during routine or emergency condition. Scoring systems shouldn't be used alone to determine the level of care or removal from higher levels of care. Documentation of patients, wishes for the right decision making and signing consent on their behalf when they are not able to do so should be done before admitting to ICU whenever possible. DNR or do not associate status should be determined before and during ICU stay to determine the need for critical care. Criteria for COVID-19 ICU admission. Patient require invasive mechanical ventilation. Patient require more than 2 hours on non-invasive ventilation or high flow nasal cannula, respiratory distress need. Rapid escalation of oxygen requirement, significant work of breathing, such as patient with hemodynamic instability despite initial conservative fluid dissociation, patient requiring vasopressor support, patient with a decreased level of consciousness, patient with acidosis defined as the following: arterial blood gas with pH less than 7.3 or PCO2 more than 50 or above patient's baseline, lactate more than 2. Patient with more than one organ failure. Patient requires continuous renal replacement therapy, CRRT, and cannot tolerate hemodialysis. Patient with unstable vital sign, patient with unstable vital signs, not yet on vasopressor. Patient with new ACG finding include ischemia, arrhythmia, heart block, preferred to be in CCU if available. ICU discharge general recommendations. Patient should be discharged from the ICU to a lower acuity area when a patient's physiologic status has stabilized and they are no longer a need for ICU monitoring and treatment. Discharge parameters are based on ICU admission criteria, the admitting criteria for the next lower level of care, institutional availability of these resources, patient prognosis, physiologic stability, and ongoing active intervention. Discharge from the ICU is appropriate despite deteriorate patient's physiological status if active interventions are no longer planned. Transferring patients to lower acuity care area shouldn't be based solely on severity of illnesses scores. Avoiding discharge from ICU after working hours unless there is a high need for bed and with transfer approval from the consultant. Standardized process for discharge from the ICU be followed in written format. Criteria for ICU COVID-19 discharge. Stable vital signs and other hemodynamic parameters without intravenous inotropic or vasopressor support. Patient on low dose inotropic support less than 5 microgram per kg per minute of dopamine may be discharged earlier if ICU bed is required during the crisis. Normal or baseline level of consciousness, stable respiratory status, normal airway patency, and normal work of breathing. At least 24 hours post-extubation if the patient was on mechanical ventilation, no or controlled cardiac dysarrhythmia. No frequent suctioning requirement for a patient on chronic mechanical ventilation. No frequent suctioning requirement for a patient with tracheostomy. Patient with no escalation decision and DNR. Outreach ICU general recommendations. Outreach ICU rapid response team to be utilized for early review of acutely ill non-ICU patients. This will aid in early identification of ICU eligible patients and prevent unnecessary ICU admission. Also, it promotes early intervention that prevents patients' health deteriorations. ICU consultant on-call teams facilitate transfer to ICU and reduce rates of readmission to critical care. No ICU admission for a patient with a low probability of recovery who choose not to receive cardiopulmonary resuscitation. ICU outreach can initiate and encourage DNR policy in the ward. Follow-up discharged patient from ICU for 24 to 48 hours to reduce the rate of readmission. The transmission of SARS-CoV to neonates is thought to be predominantly to occur primarily through respiratory droplets during the postnatal period when neonates are exposed to mothers or other caregiver with SARS-CoV-2 infection. Limited published reports have raised concern about possible intrauterine, intrapartum, or prepartum transmission. Approximately 2 to 5% of infants born to mother with positive COVID-19 have positive SARS-CoV-2 positive test in the first 24 to 96 hours. Their immature immune system leaves newborns vulnerable to other severe respiratory viral infection, which may cause severe disease among neonates. In ICU, neonate born to the mothers who are suspected or confirmed COVID-19 infection can be divided to three main groups. First, healthy baby. Second, asymptomatic, infected or mild disease neonate born at or near term who doesn't require neonatal intensive care. Symptomatic or high-risk neonate requiring neonatal intensive care admission. Preterm infants, less than 37 weeks gestational age, and the neonate born with comorbidities may be at higher risk of severe illness from COVID-19. Clinical finding. Neonates with COVID-19 infection are classified according to the presence or absence of apparent symptoms and signs. The clinical manifestations may be asymptomatic, mild, or severe. Clinical finding, especially in premature infant, are non-specific. Therefore, it's important to closely monitor vital signs, respiratory and gastrointestinal symptoms and signs. The sign may include temperature instability. The temperature of an infected infant may be elevated, depressed, or normal. Respiratory and cardiovascular signs may include tachypnea, grunting, nasal flaring, increased work of breathing, apnea, cough, or tachycardia. Other findings may include poor feeding, lethargy, vomiting, loose stools, and abdominal distension. Laboratory finding. Laboratory examinations may be non-specific. CBC may show normal or decreased leukocyte counts or decreased lymphocyte counts. Other findings may include a mild thrombocytopenia, elevated level of creatine kinase, alkaline phosphatase, alanine aminotransferase, aspartate aminotransferase, and lactate dehydrogenase. COVID-19 can be detected by PCR, upper respiratory tract, nasopharyngeal or oropharyngeal. Lower respiratory tract can be detected by endotracheal aspirate or bronchoalveolar lavage, the blood by serology test, and the stool by PCR. Radiography finding. Chest radiograph or lung ultrasound is likely to show pneumonia. Abdominal radiograph may show the characteristic radiographic features of intestinal areas. Delivery room management and resuscitation. Delivery should be conducted in isolation room with negative pressure. If not available, use single room with HEPA filter. Full maternal assessment done, including temperature, oxygen saturation, respiratory rate, pain score, and obstetric examination. Currently, there is no evidence favoring one form of delivery over the other unless women's respiratory condition require urgent delivery. The neonatal team should be informed as soon as possible of maternal admission of suspected or confirmed COVID-19, and the associated and room equipment should be checked before the mother enters the room. The number of healthcare workers handling the neonate should be kept to a minimum. The neonatal team for dissociation should be identified and prepared with the adequate time given to don personal protective equipment. All healthcare workers caring for these newborns should do PPE, including disposable gowns, surgical mask, face shield, and gloves. Continuous fetal monitoring for newborns not protected to need extensive resuscitation. A competent neonatal delivery nurse enters the room immediately after delivery and evaluates the gestational age, tone, color, and respiratory effort. If there is good tone with spontaneous breathing, the nurse wraps the newborn with warm blanket and places her or him into a pre-warmed transport incubator and transfer the neonate to the designated isolation room in postnatal ward. For resuscitation of premature high risk and newborns with anomalies born to mother with confirmed or suspected COVID-19 stabilization, they should use airborne, droplet, and content personal protective. The neonatal team are required to perform equipment. This includes gown, gloves, eye protection, goggles or face shield, and N95 mask, and air purifying respirator. Resuscitation of the baby should be in a separate isolation room. Commonly used neonatal resuscitation equipment should be readily available, for example, located in disposable grab bags to avoid taking the full resuscitation trolley into the room unless required. The obstetric nurse should hand the neonate to the neonatal team. The stabilization of the neonate should be according to the neonatal resuscitation program guidelines. Delayed cord clamping practice should continue as per usual center practice. If implementing delay cord clamping practices, mothers with COVID-19 should use a proper mask. Initial steps. Routine neonatal care and the initial steps of a neonatal resuscitation are unlikely to be arousal generating. They include drying, tactile simulation, placement into a plastic bag or wrap, assessment of heart rate, placement of pulse oximetry, and ECG leads. Suction. Suction of the airway after delivery shouldn't be performed routinely for clear or meconium-stained amniotic fluid. Suctioning is an aerosol-generating procedure and is not indicated for uncomplicated deliveries. Before initiating positive pressure ventilation or intubation, use a bag mask device or T-piece in neonate with a HEPA filter and a tight seal. The endotracheal tube must be clamped while switch from bag and mask ventilation to transport ventilator. Endotracheal medications. Endotracheal installation of medications such as surfactant or epinephrine are aerosol generating procedures, especially via an cuff tube. Intravenous delivery of epinephrine via low-lying umbilical venous catheter is the preferred route of administration during neonatal resuscitation. Post-stabilization, the neonate should be transferred to designated isolation room in ICU via the designated transport incubator with ventilator without undergoing any non-urgent neonatal care. The equipment used should undergo terminal cleaning or disposed of based on universal recommendations following a biohazard documentation protocol. Endotracheal installation of medication, such as surfactant or epinephrine, and intravenous delivery of epinephrine that previously said. Skin-to-skin contact. All neonates should be separated from their mothers with no skin-to-skin contact. Healthy asymptomatic neonates. Newborns should be physically separated at birth from mothers with suspected or confirmed COVID-19 infection. The healthy asymptomatic neonate should be admitted outside in ICU to isolation room with negative pressure. If an isolation room with negative pressure is not available, admit in designated room using HEPA filter in postnatal ward. Infant should be placed in air temperature controlled incubator and maintained at least 2 meters apart. Healthcare workers should use gown, gloves, standard procedure mask, and eye protections when providing care for well infants. Newborns should be bathed once the temperature is stable after birth to remove various potentially present on skin surface. Promptly notify infection control team. If the mother's result is tested negative for COVID-19 infection and the neonate is symptomatic and stable, transfer the baby to the mother and discharge the newborn with follow-up. If the mother's result is tested positive for COVID-19 infections, collect the oronasopharyngeal swab for the newborn at 24 hours of age and continue routine care. Repeat the second swab at 48 hours. That's when the mother result is tested positive and the first swab of the neonate was negative. We need to repeat it after 48 hours. If the neonate's second swab result is tested negative and the neonate is asymptomatic, discharge the baby with negative caregivers after 2 negative results. If the neonate stays in the hospital, transfer the baby from the isolation room or discontinue the isolation only after 14 days. If the mother's result tested positive and the neonate first and second swab result is positive, repeat the sample every 48 to 72 hours until the swab result turns negative. If the neonate is asymptomatic, discharge once negative for 2 consecutive samples to COVID-19 negative caregivers. In order to minimize PPE use and potential exposures in the postnatal care, routine newborn tests such as screening for congenital heart disease, obtaining the newborn metabolic screen, and newborn hearing screening are performed together. Symptomatic neonate requiring neonatal intensive care. Infants born requiring neonatal intensive care optimally should be admitted to a single patient room with negative pressure or using HEPA filter. If a single isolation room is not available, admit in designated room using HEPA filter in ICU. Infant should be placed in air temperature controlled incubator and maintained at least 6 feet equals 2 meters apart. Promptly notify infection control team. All attending healthcare workers must wear PPE before entering the room, including gown, surgical mask, face shield, and gloves. Droplet precautions should be followed if the baby has respiratory illnesses, where they will be in an incubator until improved. This means a surgical mask, gown, gloves, and eye protections. N95 masks are not required for healthcare workers during the routine care of symptomatic neonate if suspected or confirmed COVID-19 positive mother, even if they requires CAB or mechanical ventilation. Surgical masks are adequate except in the aerosol generating procedures. Surgical mask required when the patient contact usual practice of gloves with nappy changes and wash hands thoroughly before and after handling the baby. It's acceptable to wear the mask for 4 hours or till your meal break as long as the mask remains dry. Note, surgical mask should be used as a routine practice. For intubation or extubation or suctioning or nasopharyngeal sampling, N95 mask and goggles needs to be used as well as gown and gloves. Full personal protective equipment. Before initiating BBF or intubation, use a bag mask device or T-piece in neonate with HEPA filter and a tight seal. The endotracheal tube must be clamped while switch from bag and mask ventilation to mechanical ventilator. All body fluids and lines are treated as potential biohazards. Soiled liens should be disposed of according to COVID-19 infection prevention and control measures. Lab investigations and diagnostic procedures should be requested based on the clinical condition of the baby as indicated. If the mother's result is tested negative for COVID-19 infection, transfer out the neonate from the isolation room and continue the close monitoring and supportive care management. If the mother's result is tested positive for COVID-19 infection, collect the nasal oropharyngeal swab from the newborn at 24 hours of age. Continue the close monitoring and supportive care management. If the mother's result is tested positive for COVID-19 infection at the neonate, first swab result is negative. Repeat the second swab at 24 hours. And if then the neonate second swab result is tested negative, continue the supportive care and management. Transfer the baby from the isolation room or discontinue the isolation only after 14 days. If the mother's result is tested positive for COVID-19 infection and the neonate first swab result is positive, continue close monitoring and supportive care management. Repeat the sample every 48 to 72 hours intervals until the result turns negative. If the neonate is fit for discharge with COVID-19 negative result for 2 consecutive samples. Transfer the baby from the isolation room or discontinue the isolation after the two negative swab results. Mechanical ventilation protocol for COVID-19. Coronavirus disease, or COVID-19, is a novel strain of the coronavirus family since the first appearance of the disease in Wuhan, China, in December 2019. The virus has proven to be highly infectious, affecting more than 4 million cases worldwide. 5 to 10% of the infected patients require critical care admission and a sort of respiratory support ranging from high flow nasal cannula to the invasive mechanical ventilation. Respiratory support for COVID-19 patients. Supplemental oxygen. If endotracheal intubation is not indicated and the patient is tolerating supplemental oxygen, do the following. Closely monitor the patient for worsening in vital sign and work breathing. Target peripheral capillary oxygen saturation, SpO2 at 92 to 96%. Consider awake proning of the patient. Ensure appropriate infection control recommended. Precautions are in place as per Saudi Center of Disease Control. Don't delay endotracheal intubation if the patient condition worsens. High flow nasal cannula. If endotracheal intubation is not indicated and the patient is not tolerating supplemental oxygen, consider using high flow nasal cannula. If this is tolerated, do the following. Close monitor the patient for worsening vital signs and work for breathing. The target SpO2 at 92 to 96%. Also consider awake proning of the patients. Ensure appropriate infection control recommended. Precautions are in place as per the CDC. Preferable negative pressure room, and if not available, room with HEPA filter as per SCDC recommendations. Don't delay endotracheal intubation if the patient's condition worsens. Non-invasive positive pressure ventilation. If endotracheal intubation is not indicated, the patient is not tolerating supplemental oxygen and the patient is not tolerating high flow nasal cannula, or it's not available, do the following. Consider non-invasive positive pressure ventilation. Closely monitor the patient at short intervals. Ensure appropriate infection control recommended. Precautions are in place as per CDC. Preferable negative pressure room, and if not available, room with HEPA filter as per CDC recommendations. Don't also delay endotracheal intubation if the patient condition worsens. Mechanical ventilation. Indications. Increased work of breathing and sign of organ failure. For example, there is a changes in the mental status, like the patient, he doesn't aware where he is or what is the time. That's indication of mechanical ventilation. Low blood pressure, increased lactate, and signs of cardiac ischemia. Acute hypoxic respiratory failure, not responding to high flow nasal cannula or non-invasive ventilation for maximum of 2 hours, hypoxia with acute decreased level of consciousness and cannot protect his airway. Hypoxia with large secretions, hypercapnic respiratory failure, not responding to high flow nasal cannula nor non-invasive ventilation. Hemodynamically unstable. Consider for patient on high flow nasal cannula or non-invasive ventilation therapy and for transfer by ambulance. Different COVID-19 patterns were found at presentation depending on the interaction between three factors. First, severity of the infection and the host response, physiological reserve, and comorbidities. Ventilatory responsiveness of the patient to hypoxemia, time elapsed between the onset of the disease and seeking medical advice. These interactions lead to the development of a time-related disease spectrum within two primary phenotypes, type L and type H. Type L, characterized by low elastance, high compliance, low ventilation to perfusion ratio, and low lung weight and low recurability. Type H, characterized by high elastance, high ratio to left shunt, high right to left shunt, and high lung weight and high recurability and impressive non-uniform. According to this classification, we recommend the following. Volume protected strategy is recommended. Tidal volume 6 to 8 ml per kg, predicted body weight, limit blood pressure to less than 30, respiratory rate 15 to 20 per minute with permissive hypercapnia. Start PEP with 5 to 10 centimeter H2O, titrating up and down according to patient's response. Apply lung protective strategy with following target: SpO2 90 to 95, VO2 60 mm, arterial pH more than 7.30, and LP plate less than 30, and driving pressure less than 15. Assess lung strain and recruit ability if the driving pressure equals plateau pressure. Keep the same and keep the tidal volume the same, and if the driving pressure more than 15, reduce the tidal volume to achieve the targets. Assess pneumonia phenotype by assessing the compliance. Static compliance equals tidal volume over plateau pressure. If respiratory system compliance more than 40 over 20, L phenotype, consider keeping PEP 5 to 10. If respiratory system compliance less than 40 ml H phenotype, BEP titration guided by BEPP over FiO2 tables or recruitment maneuver don't exceed BEP 15. Neuromuscular blocking agent to be used as intermittent boluses as needed or for 48 hours if the PO2 ratio less than 150 as per ARDS protocol to facilitate lung protective strategy. Daily sedation, vacation and assessment of sedation requirement and its depth as per Richmond scale. Braun is recommended for patient with refractory hypoxemia. It should be done for 16 hours at least. Figures. One, this is a guide for prone position of awake patient with COVID-19 to achieve SpO2 from 90 to 92 and with suspected or confirmed COVID-19 patient. If the patient is able to communicate and cooperate with the procedure, rotate to a front and adjust position independently. No anticipated airway issues without absolute contraindication for prone position. Immediate need for intubation, acute brain injury, unstable spine, thoracic injury, and recent abdominal surgery. Relative contraindication. For example, if the patient has facial injury, morbid obesity, pregnancy in the second or third trimesters, pressure sores, or ulcers. Proceed. Assist patient to prone position, explain procedure and benefits, ensure oxygen therapy and basic respiratory support, secure with adequate length on the tubing. Pillows may be required to support the chest. Reserve position may aid comfort. Monitor SpO2, avoid sedation to facilitate proning. For 15 minutes, SpO2 90 to 95 and acceptable workover breathing. If it's yes, continue proning's process. Change position every 30 minutes to 2 hours, aiming to achieve a prone time as long as possible. When not in prone, aim to position upright between 30 to 60 degrees. Monitor SpO2 for 15 minutes after every position change. Schedule for position change. Full prone, bed flat, right side, bed flat. Sitting up, it will be 30 to 60 degree, left side, bed flat, prone again, repeat the cycle. If the SpO2 for 15 minutes, less than 90%, ensure oxygen is connected to the patient, increase inspired oxygen, change patient's position, consider return to spine position. Discontinue the prone position if first, no improvement or with the change of position, patient unable to tolerate position, high work for breathing. Airway management in COVID-19 patients guideline. We will take a break now for 10 minutes to warm up and to have a cup of coffee. Okay. Assalamu alaikum. Everyone ready to continue? Bismillah. Airway management in COVID-19 patients guidelines. Severe acute respiratory syndrome coronavirus, SARS-CoV-2, which cause COVID-19, is a single-stranded ribonucleic acid encapsulated coronavirus and is highly contagious. Transmission is thought to be predominantly by droplet spread, relatively large particles that settle from the air and direct contact with the patient or contaminated surface, rather than airborne spread in which smaller particles remain in the air longer. Initial airway management procedures in emergency and intensive care departments may generate aerosol, which will increase risk of transmission. Healthcare workers treating patients with COVID-19 are at increased risk of contracting the illness. Tracheal intubation in critically ill patients. This is a high-risk procedure with physiological difficulty. Around 10% of patients in this setting develop severe hypoxemia and 2% experience cardiac arrest. The increased risk of infection during multiple airway manipulations necessitate the use of airway techniques which are reliable and maximize first-time success. This applies equally to rescue techniques if tracheal intubation fail at first attempt. All COVID-19 patients requiring airway management should be considered as a difficult airway, and all preparation should take into consideration at this point. Aerosol generating procedure. Aerosol generating procedures are procedures that stimulate coughing and promote the generation of aerosols. Additional infection prevention and control precautions are required for some aerosol generation procedures where an increased risk of infection has been identified. A systemic review of infection risk based on limited literature ranked airway procedures in descending order of risk as tracheal intubation, cricothyroidectomy, tracheostomy, and non-invasive ventilation. High flow nasal cannula oxygenation, mask ventilation, other potentially AGBS, including disconnection of ventilatory circuits during use, tracheal extubation, cardiopulmonary resuscitation before tracheal intubation, bronchoscopy, and tracheal suction without a closed inline system. Indication for intubation in COVID-19 patients. First, increase the work of breathing, and signs of organ failure. For example, altered mental status, low blood pressure, increased lactate, and sign of cardiac ischemia. Acute hypoxic respiratory failure, not responding to high flow nasal or nor BiPAP for 2 hours. Hypoxia with acute decreased level of consciousness and cannot protect his airway. Hypoxia with large copious secretions, hypercapnic respiratory failure, not responding to high flow nasal nor BiPAP. Hemodynamically unstable, consider inpatient on high flow nasal or BiPAP therapy and for transfer by ambulance. سامعين الصوت؟ Okay. Patients who are in respiratory distress and need assistance, a trial of high flow nasal oxygen should be strongly considered prior to intubation if available. If high flow nasal oxygen is not available and oxygenation and ventilation support is needed, intubation is recommended instead of attempting to primarily manage with non-invasive positive pressure ventilation. Non-invasive BBF or high flow nasal, if used, should be performed in a negative pressure room. If negative pressure room is not available, then the room has to have at least a HEPA filter. Previous SARS experience showed that BiPAP and manual bagging both increase the risk of airborne viral particles, and more than 90% of patients ultimately failed trials of non-invasive BBF. Intubate in a negative pressure room, and if not available, then HEPA filter should be available in the room while intubating. Avoid nebulized medication administration whenever possible. Rapid sequences intubation should be the method for intubation. During RSI, use high-dose neuromuscular blocking agent for faster and complete apnea with no residual cough. It's preferred to use rocuronium 1 milligram per kg rather than succinylcholine, as it has a longer duration and will prevent post-intubation coughing on the mechanical ventilator until patient is well sedated. This figures for a suspected patient with respiratory failure. If critically ill patient suspected with COVID-19 and has respiratory failure, there's two pathways. If the patient is conscious and stable, so self-proning, high flow nasal cannula, and in negative pressure room for sure with full BBF precaution and assess in 2 hours. If the patient condition is unconscious or hemodynamically unstable or has multi-organ failure, put patient on monitored bed, start high flow nasal cannula, IV bolus, and start RSI. If the patient feels well, then admitted to the ward. If the patient doesn't feel well or his oxygen saturation doesn't improve, then admit to ICU. The 7 P's approach should always be used in intubation. Preparation. 3 HCW should be available during the procedure. 1, to intubate. one to assist respiratory care practitioner or a nurse, and one to give the medication. Two, full personal protective equipment should be applied before intubating: surgical or yellow gown, face shield, N95 mask, double gloves, head cover, foot cover. Procedure should be done in a negative pressure room. If not available, the room should have HEPA filter. The minimal number of healthcare workers should be in the room. The most expert person should be the one who intubates the patient, preferably anesthesia if available at time of intubation. The patient should have 2 large bore peripheral IV cannula from 14 to 16 gag before intubation. An intubation trolley should be always prepared and ready in the ICU or emergency department. This should include oral airways, different sizes, nasal airways, different sizes, and multiple ETT styles. Laryngoscope with size 3 and 4, oxygen tubing, elastic bogey, and 10 or 15 cc syringe. Yanker suction tubing, EtCO2 detector, ETT securing device, and for sure stethoscope, and preferred the disposable one. Pre-oxygenation. Pre-oxygenation should be done by non-rebreathable oxygen mask on 15 liters per minute. Manual bagging and PPF should be avoided and only performed if clinically required. Low volume and higher frequency approach if bagging is required. Pre-medication, atropine. If patient develops bradycardia secondary to intubation, the dose 0.5 to 1 milligram IV line. Phenytoin in case patient has high blood pressure, systolic blood pressure more than 180. Before intubation, the dose 0.5 to 1 microgram per kg, and the route is IV. Phenylephrine in case of low blood pressure, the systolic blood pressure less than 90 during intubation, the dose is 50 to 100 microgram IV, or ephedrine in case of low blood pressure during intubation, and the dose is 5 to 25 milligram. Paralysis and sedation. Option 1, etomidate. 2, propofol. 3, midazolam and phenytoin, and the last one, ketamine. Option 1, rocuronium, 30 to 60 seconds to have effect, longer duration, and the dose needed is 1 milligram per kg. And the succinyl alcoholic is 5 to 15 seconds to have its effect, but the duration is short, and the dose need is 1.5 milligram per kg, and should be avoided in CRF patients, burn patients, neuromuscular disease patient, large stroke patients, and malignant hyperthermia. Altitude. The most expert intubator around should be the intubation, should do the intubation after assuring full PPE, personal protective equipment, a cuffed ETT size 8 to 8.5 in male patients and 7 to 7.5 in female patients should be placed with video-assisted laryngoscopy. For example, kaleidoscope. 10 to 15 cc syringe full of air should be used to inflate the ATT balloon to secure it. Once tube is inserted in the airway, viral filter, or if not available, then the HME filter should be connected on the ATT before connecting to the ampoule bag. ETCO2 should be connected to the ampoule bag to confirm placement of ATT. Auscultation of the chest to confirm air entry in both lungs with disposable stethoscopes if available. ATT should be immediately secured by ATT securing device. Assess patient vital signs and saturation immediately post-intubation. Start patient on sedation infusion immediately. Insert an NGT or OGT. Connect the patient to the ventilator with appropriate setting and assure close suctioning system. Order chest X-ray for the patient to confirm the placement. Reduce personal contamination. First, enhance droplet by personal protective equipment. Ponent N95 or barb goggles, face shield, gown, and gloves fold over end of gown sleeves. Follow all donning and doffing procedures with observe ensure compliance. Only clinicians that have completed PPE training can intubate. Minimize number of clinicians in the room needed to complete the intubation. Limit to a 3-person intubation team when possible. Primary nurse and respiratory team and the medical. SARS experience revealed that cross-contamination was highest when more than 3 people were in the room. These figures for the sedative medications, the name of the drugs and the dose and the advantage and disadvantage of each one. For example, like Otimidate, the dose is 0.3 milligram per kg. The advantages is it's rapid announced, ultra short duration, reduce ICP, no effect on hemodynamics, but the disadvantages, nausea and vomiting and adrenal insufficiency, which is rare. Propofol 1 to 1.5 milligram per kg, rapid and onset for short duration, reduce ICP, intracranial pressure, and anti-nausea and anti-seizure. But the disadvantages, it will lower the blood pressure and there will be pain at the site of administration. So we need to use a large pore cannula and large peripheral veins. Allergy, very rare, and in people with anaphylaxis secondary to AIDS. Ketamine, the dose is 1 to 1.5 milligram per kg. Rapid announced, the duration lasts 10 to 15 minutes. Analgesic effect, and it has effect on the bronchioles. It leads to bronchodilator and no effect on hemodynamics and improve the CPP. But the disadvantages, it causes masseter's muscle spasm and urgency and hallucination. Midazolam, the dose is 0.05 to 0.1 milligram. It's rapid in onset for short duration and has anti-seizure effect. The disadvantage, it's negative inotropic effect and variable effect. Fentanyl 1 to 2 microgram per kg, analgesic, faster in onset, the duration 30 to 60 minutes. Decrease sympathetic stimulation. Disadvantage, negative inotropic effect and acute chest rigidity syndrome. Paralytic agents for intubation, rocuronium 0.6 to 1 milligram per kg. Advantage, it has no side effect. The disadvantage, longer action, 30 to 60 seconds, and the duration 30 to 60 minutes. And the last one, the succinylcholine 1 to 1.5 milligram per kg. The advantage is rapid in onset, 10 to 15 seconds, and the duration 6 to 10, which is short. But the disadvantage, it causes hyperkalemia, malignant hyperthermia, and cardiac dysarrhythmias, and masseter muscle spasm, and increase intraocular pressure. I don't know, but I guess the Ministry of Health will update it, the regulation and everything after lifting some restriction. I think everyone see it yesterday. So I guess there will be a new guidelines because, you know, that's a new disease for us and we don't know the nature of COVID-19. So it's hard to deal with, but Ministry of Health and the government done a greatly humanity job to save lives and to provide us with all health that we need, and the vaccination program while, and I can't wallahi say anything more, but يعني شكرا على جهودهم العظيمة. بالنسبة لأوميكرون، على الدراسات الأخيرة اللي last studies, Omicron has the lowest يعني between the different kind of COVID-19. إنه الأوميكرون, yes, it spread very fast, but with very minimum symptoms, and most of the case doesn't need any hospital admission, and we can live with it. Okay, I don't know wallahi about this, but you know, it's a new disease, so we need to review it, and the research is going on and on and on, and the guidelines always changes. إن شاء الله في محاضرة ثانية بعد صلاة المغرب بعون الله بتوقيت الرياض. يعني إن شاء الله المحاضرة الثانية راح تبدأ الساعة 6 و10 مع دايتيشن غنيم. وشكرا لحضوركم واستماعكم، وإن شاء الله أن ما نكون ثقلنا عليكم، ويعطيكم العافية.
and to practice suitable exercise. Also, patients at risk for poor outcomes and higher mortality following infection with COVID-19, older adults also, and polymorbid individuals should be checked for moral malnutrition through screening and assessment. Sorry, I had an internet issue. So as we were saying, for critical care nutrition, first nutrition support is the provision of a nutrient via tube that is placed in the stomach or small intestine, which is referred to as enteral nutrition, or via tube that is placed intravenously, which is referred to as parenteral nutrition. For patients who are unable to eat adequately when provided a normal diet. The aim of this tube feeding is to prevent or treat malnutrition. Also, nutrition support usually is for patients who need critical care, so it is considered as a part of critical care for the patient. COVID-19, patient with COVID-19 with also respiratory failure may need admission to ICU. And since there is no definitive treatment for COVID-19, good supportive care remains the cornerstone in managing critically ill patients with COVID-19. And the need to address the provision of critical care nutrition remain an integral component of these supportive measures. The nutritional management of patients with respiratory failure due to COVID-19 is in principle same as critical care nutrition provided to ICU patients who are admitted with respiratory failure. And given the lack of direct evidence on patients with COVID-19, especially those with shock, many of these recommendations are based on indirect evidence from critically ill patients in general and those with sepsis and acute respiratory distress syndrome. In terms of dietary planning for ICU patients, for the energy need and according to the SPIN expert statement and practical guidance for nutritional management of COVID-19 in 2020, they recommend to give patients 27 kilocalorie per kilogram of body weight and per day. Also, the total energy expenditure for polymorbid obese patients aged more than 65 years should be 27. And the energy need can be assessed using indirect calorimetry if safely available with insurance that it is sterilized by the measured system. The target of 30 kilocalorie per kg in severely underweight patients should be cautiously and slowly achieved. Therefore, we should start gradually by almost 20 kilocalorie per kg until we reach 30, as this is a population at a high risk of refeeding syndrome. The Society of Critical Care Medicine and the American Society of Parenteral and Enteral Nutrition recommend that feeding should be initiated with low doses and increased slowly to full dose to meet the energy requirement within 1 week. And in older patients, the energy need should be 30 kilocalorie per kg. These values should be individualized and adjusted with regard to the nutritional status, physical activity level, disease status, and finally, the patient tolerance. For protein need, it is usually estimated using formulas such as 1 gram of protein per kg of body weight per day in older persons. And the amount should be individually adjusted with regard to the patient's nutritional status, physical activity level, disease status, and patient tolerance. In polymorbidly obese patients, they should be given more than 1 gram of protein per kg, which could be reaching 20% of their total caloric intake, in order to prevent the body weight loss and reduce the risk of complications and hospital readmission, and of course, to improve the functional outcome. Fats and carbohydrates, while considering energy ratio from fat and carbohydrate between 30 to 70, which is subject with no respiratory deficiency, and we can minimize it or optimize it to 50 of fat and 50% of carbohydrate for patient on mechanical ventilation. For vitamins and minerals should be individually adjusted according to the recommended dietary allowance, patient age, and gender. According to the SBIN expert statement and practical guidance for nutritional management of COVID-19, they recommended the following: that subject with malnutrition should ensure sufficient supplementation with vitamins and minerals with the recommended dietary allowance. For patients who are using formula with higher caloric density, patients with pulmonary disease, failure, they can benefit from water restriction. Higher caloric density can be helpful in these cases. Hospitals for nutrition counseling. First, the step one is to start early nutrition screening using early nutrition screening forms. This is done usually by the nurse and is done in the ER at the patient admission. Based on this assessment, the nurse will determine if the patient needs special diet or doesn't need one. So if the patient needed a special diet, the second step would be to use a nutrition assessment and diet plan using the nutrition assessment forms, which is the responsibility of the clinical dietitian in the outpatient clinic or in the inpatient wards or ICU. Afterward, the dietitian will determine to put the patient on parenteral nutrition or to have a regular diet. Afterward, the patient will have a nutritional follow-up and a nutritional reassessment. Also should be done by the clinical dietitian in the outpatient unit or the hospital wards. Afterward, if the patient needed, they should recommend him for a follow-up in the outpatient clinic or continued nutrition support at home. The timing of nutrition delivery is as important as the intervention itself. And the aim is to start early enteral nutrition within 24 to 36 hours of admission to the ICU or even within 12 hours of intubation and placement of mechanical ventilation. Patients with sepsis or circulatory shock can tolerate trophic feeding, which is the small volume of balanced enteral nutrition insufficient for patient nutritional need, but can produce some positive gastrointestinal or systematic benefit. The shifting to parenteral nutrition should be lowered when starting with the doses. According to ISPEN, the nutritional treatment should start early during hospitalization within 24 to 48 hours of admission, especially for older patients and morbidly obese ones whose nutritional conditions can be already compromised, and the nutritional treatment and target should be met gradually to prevent refeeding syndrome. For oral nutritional supplements, it should be used whenever possible to meet the patient need and when dietary counseling and food fortification are not sufficient to increase the dietary intake and to reach the nutritional goals. Also, oral nutrition supplements shall provide at least 400 kilocalories per day, including 30 grams or more of protein per day, and shall be continued for at least 1 month. The efficacy and expected benefit of oral nutritional supplements shall be assessed once a month after administration. For choosing the route of feeding, generally there are 3 methods of feeding. First is enteral nutrition or tube feeding for those who cannot eat normally and the gastrointestinal tract at all or a part is functioning normally. This type of feeding is need a professional expert for tube feeding. The second one is parenteral feeding, which also need a professional expert to be administered. The third type is oral or normal feeding. To start tube feeding, there are indications that need to be met first. These include for patients who cannot or will not eat, and patients who have a functional gut, and when it is considered as a safe method of access possible. There are also different methods of administering tube feeding, such as continuous drip feeding, which is referred to as continuous drip method. It is the mostly common used one and is administered via gravity or a pump and is usually tolerated better than bolus feeding. The second method of tube feeding is bolus feeding, which allows for more motility than the continuous drip feeding. The third type is a combination between the continuous drip and the bolus feeding, which can be usually administered as a continuous feeding at night and bolus feeding during the day. For patients with COVID-19, enteral nutrition is preferred to parenteral nutrition, and infusion of formula into the stomach feeding nasogastric tube can require minimal expertise. If gastric feeding is unsuccessful due to enteral feeding intolerance, use of a prokinetic agent to enhance the motility, and which is recommended as the second step. Also, post-biologic enteral nutrition delivery is recommended only after these first strategies has failed. Placement of any enteral access devices can provoke coughing and should be considered as an aerosol generating procedure. And if possible, keep the patient mouth covered during the placement in the nurse and follow the CDC guidelines regarding the use of an N95 mask and the PARP during tube placement. And finally, placement of a post-biliary feeding tube may take longer to place than other routes of feeding, which can increase the exposure time of a healthcare practitioner to the patient who is infected with COVID-19. Early enteral nutrition may not be preferential in a subset of patients with COVID-19 who have gastrointestinal involvement before the onset of their respiratory symptoms. Some of the patients initially present with diarrhea, nausea, vomiting, abdominal discomfort, and in some cases, gastrointestinal bleeding. And when present, early use of parenteral nutrition should be considered, transitioning to enteral nutrition when a GI symptom has subsided. Also, in polymorbid medical inpatient and in older person with a reasonable prognosis, the nutritional requirement cannot be met orally. Enteral nutrition should be administered immediately. And parenteral nutrition should be considered when enteral nutrition is indicated or unable to be reached the target for feeding. When choosing tube feeding, there are different delivery systems. There are two types of delivery systems. The first is open, or the second is closed tube feeding. And depending on how a tube feeding product is packaged, infusion is via an open or closed delivery system. The open system can utilize either a large syringe or an open top container for tube feeding delivery. And the products include a flip-top cans, bottles, brick packs, or powder package that require reconstitution with water at a formula room. While the closed system, a container is pre-filled with sterilized tube feeding product, and the bottle is then spiked with tube and attached again to the enteral access device. The container usually consists of at least 1 liter of product and formula hang time, which is usually between 24 to 36 hours, as long as it is a sterilized technique used. This picture can show us the difference between an open system and the closed system. The closed system can, of course, reduce the contamination. For patients with COVID-19 in an ICU unit, closed system tube feeding is recommended if the suitable nutrition formulas are available. According to employment and in older persons with reasonable prognosis whose nutritional requirement cannot be met orally, enteral nutrition should be administered. And parenteral nutrition, as we said, should be considered when enteral nutrition is not indicated or unable to reach their target. Enteral nutrition should be implemented when the nutritional need can be met by the oral route. And if oral intake is expected to be impossible for more than 3 days or expected to be lower than half of their energy requirement for more than 1 week. In these cases, the use of enteral nutrition may be superior to parenteral nutrition because of a lower risk of infection and non-infectious complication. We need to monitor for enteral nutrition potential complication, which should be performed in a specified timeline. In COVID-19 patients who are non-intubated ICU, who are also not reaching their energy target with an oral diet or a nutrition supplement should be considered first, then enteral nutrition support. If there are limitations for the enteral route, it could be advised to prescribe peripheral parenteral nutrition in the population not reaching the energy protein target by oral or enteral nutrition. And in COVID intubated and ventilated ICU patients, enteral nutrition should be started through a nasogastric tube, or a post-pyloric feeding tube should be performed in patients with gastric intolerance after prokinetic treatment or in patients who are at high risk for aspiration. Also, using the prone position per a sedated patient doesn't represent a limitation or contraindication to enteral nutrition. And in these cases, continuous feeding rather than bolus enteral nutrition should be used. In 5 studies that were identified by the ESPEN meta-analysis, they found a significant reduction in diarrhea with continuous versus bolus administration. And in patients with gastric feeding intolerance not solved with prokinetic agent, post-pyloric feeding should be used. And in critically ill patients with gastric feeding intolerance, intravenous erythromycin should be used as a first-line prokinetic therapy. Alternatively, intravenous metoclopramide or a combination of metoclopramide and erythromycin can be used as a prokinetic therapy. And gastric access should be used as the standard approach to initiate enteral nutrition. And in patients deemed to be at a higher risk for aspiration, post-pyloric, mainly jejunal feeding, can be performed. For nutritional doses, with patients who have mild symptoms, normal dietary intake should be initiated. And when patient is admitted to the ICU unit, feeding should be initiated with a low dose enteral nutrition as a hypochromic or trophic diet. Also increase slowly to full dose to meet the energy requirement within 1 week and to reach 15 to 20 kilocalorie per kg per day of the actual body weight, which should be about 70 to 80% of the total caloric intake. And protein goals should be between 1.2 to 2 grams per kg per day of the actual body weight for patients in the ICU. For ICU patients with dysphagia, texture-adapted food can be considered after extubation if swallowing is proven unsafe, and enteral nutrition should be administered immediately. And in cases with a very high aspiration risk, post-pyloric enteral nutrition, or if not possible, temporary parenteral nutrition during swallowing training with removed nasoenteral tube can be performed. Enteral nutrition should be withheld in the patient with hemodynamic instability who are requiring vasopressor support at a high or escalating doses, and patients on multiple vasopressor agent or rising lactate levels. Also, enteral nutrition may be initiated or restarted after the patient is adequately resuscitated or has been on a stable vasopressor dose with a sustained mean arterial blood pressure of more than 65. Also, enteral nutrition should be held and parenteral nutrition strongly considered in patients with gastrointestinal intolerance, such as abdominal pain, nausea, diarrhea, significant abdominal distension, dilated loops of the small and large bowel, and increasing the nasogastric output in previous 6 to 12 hours with starting of trophic feed or prior to initiating enteral nutrition. If the patient was mechanically ventilated, enteral nutrition should be followed as the following guidelines. First, mechanically ventilated patients are unable to take food orally and therefore are dependent on enteral nutrition for provision of energy and protein and other nutrient requirements. Also, enteral nutrition is supportive therapy and may impact the patient's outcome in the intensive care unit. And early enteral nutrition has been shown to decrease complication and hospital length of stay, and it can also improve the prognosis at discharge. For formula selection, the importance of choosing the appropriate formula is as important as choosing the route of feeding. Proper nutrition is needed for anabolism, recovery, and maintenance of optimal nutritional status. Formula selection is critical to the success of the nutrition therapy, both in terms of satisfying the metabolic requirement and increasing the gastrointestinal tolerance. Before initiating the feeding, select an appropriate formula based on the patient's specific needs. It is also important to know the intent before choosing it. Steps that to choose the appropriate formula. First, we need to evaluate the patient's nutritional status. Second, to determine the amount of nutrients needed, and to discuss with the doctor in charge to determine the route of feeding. Then we need to select the appropriate nutrition formula based on the previous steps. And as there are different routes of feeding, there are different categories or types of entered formula. First, we have the biolomeric formulas, either the commercial or the blenderized one. Second is the oligomeric formulas, these specific formulas. We also have modular formulas, which are concentrated protein carbohydrate preparation that enhance the protein and caloric of the entered formulas. And finally, we have the standard or intact protein meal replacement formula that can also contain fiber or hydrolyzed pre-digested protein, typically in small peptides. We have also different formulas based on the specific diseases, such as formula that are suitable for patients with pulmonary disease who are having CO2 retention or on a mechanical ventilation, and formula clinically significant in reducing the CO2 production, which are called the pulmonary formula, and formulas that are low in carbohydrate and high in fat content, which can also reduce the CO2 production. Also, the high caloric density with intact protein and fiber supplements are available, and some formulas contain icosapentaenoic acid and gamma-linolic acid, which are antioxidant and no arginine supplementation. Some formulas require specific mixing before giving to the patient, and these should be done in a formula room, which can help in reducing the risk of infection, and it is preferred to have the formula room away from the patient's side to prevent contamination, and it could be located in the nutrition department of the hospital. We could need the formula room to prepare the following formulas: the powder nutrition formula that need reconstitution with water, and the use of more than one formula, especially for open tube feeding system, and to add food supplements, antioxidant, or medication to the formula. After administering tubing to the patient or any nutritional intervention, we need to monitor the nutritional tolerance. And evaluation of delivery of enteral nutrition in mechanically ventilated ICU patient is very important specifically. We need to assess the gastric residual volume, and monitoring is not reliable for monitoring their nutritional tolerance. And recording the protein and caloric intake on daily basis is a must. We also need to record the protein and caloric intake on daily basis, and gastric residual volume should not be used to avoid the risk of aspiration pneumonia. And patients should be monitored by laboratory investigation and passage of stool and gases. And there are complications with tube feeding that need to be monitored or taken into account, such as infection, aspiration, diarrhea, metabolic disturbance, refeeding syndrome, alteration in drug absorption and metabolism, and these complications should be minimized as much as possible. And in the case of refeeding syndrome, we need to start with 25% of the caloric goal and then increase it gradually, either in enteral feeding, if not possible, then parenteral nutrition. Also, the assessment of serum phosphate, magnesium, and potassium level is needed to monitor to assess the tolerance. Also, the calories, as we said, to prevent refeeding syndrome. And treating this respiratory distress is a priority when managing critically ill patients. and non-invasive ventilation is increasingly used as a tool to prevent endotracheal intubation. Also, providing oral or intranutritional during the NIV may be perceived as unsafe because of the possible risk of aspiration, so that these patients are frequently denied adequate caloric and protein intake. There are newly available therapies such as high-flow nasal oxygen, which may allow for more appropriate oral feeding. For patients who are in a prone position, there are special nutritional needs that need to be taken into consideration. As several retrospective and small prospective trials have shown that internutrition during prone positioning is not associated with increased risk of gastrointestinal or pulmonary complication. Therefore, the ESPEN recommends the patient requiring prone position receive early intranutrition. Also, internutrition is not contraindicated for patients who are undergoing prone position. And when patients are stabilized and even in a prone position, enteral feeding can be started ideally after measuring their indirect with calorimetric target energy supply to provide 30% of the measured energy expenditure. Therefore, the energy administration will be increased slowly, and during emergency time, the predictive equation recommending 20 kilocalorie per kg could be used and increased gradually to 50 to 70% of the predictive energy need at almost day 2 of admission to reach 80 to 100% at day 4. And when patients are stabilized, as we said, on a prone position, the protein target of 1.3 per kg per day should also be reached by day 3 to 5. And gastric tube is preferred, but in the cases of large gastric residual volume that is above 370 to 500 milli, duodenal feeding should be inserted quickly. And the use of enteral omega-3 fatty acid may improve oxygenation, but strong evidence is missing for this recommendation. And if intolerance to enteral nutrition is present, parenteral nutrition should be considered. And blood glucose level should be maintained at the target level between 6 to 8 millimoles, along with monitoring for blood triglyceride and electrolytes, including phosphate, potassium, and magnesium. One of the major barriers to extracorporeal membrane oxygenation of enteral nutrition for patients with this disease may be safe and tolerated. And study of patients with the ECMO having enteral nutrition found that almost 5% of them developed bowel ischemia. After mechanical ventilation, some of the patients have a high incidence of swallowing problem or dysphagia, which may strongly limit their oral nutrient intake even at a time of general improvement of clinical condition. And in ICU patients who are having dysphagia, texture-adapted food can be considered after extubation. If swallowing is proven unsafe for the patient, then enteral nutrition should be administered. And in cases with a very high aspiration risk, post-pyloric enteral nutrition, or if not possible, temporarily parenteral nutrition during swallowing training with the removed nasoenteral tube can be performed. The post-extubation swallowing disorder could be prolonged for up to 21 days, mainly in the elderly, and after a prolonged intubation, which can make this complication particularly relevant to COVID-19 patients. And the presence of severe post-extubation dysphagia was associated with severe outcome, including pneumonia, pre-intubation, and hospital mortality. And recently, ICU patients have prolonged post-extubation swallowing disorder at discharge, and some post-extubation swallowing disease has been shown even 4 months after discharge, which recommended referring patients recognized to have swallowing issue for swallowing evaluation in order to prevent oral nutrition complication and malnutrition. For the pulmonary nutrition formula, we have different content of this formula, and that we will be discussing. We will be discussing 3 types of formula: the Oxpia, the Polymolecare, and the Nutrien Pulmonary. All of these formulas are indicated for patients on tube feeding, while the Pulmocare and the Nutrien are indicated also in patients needing oral nutrition. The first type is unflavored, which is more suitable for tube feeding, while the other types are flavored, which can be tolerated using oral nutrition. For the first type, it is unique in oil blended, such as the omega-3 fatty acid and the polyunsaturated fatty acid, and also they have anti-inflammatory and antioxidant properties, and it is also low in the residual volume. The Pulmocare contain about 20% of fat as MCT oils to enhance the fat absorption, and it is also fortified with antioxidants, and as the first type is low in residual. The second type, Nutrien, is almost identical to the Pulmocare, and it is all indicated in patients who are critically ill, and the first one in patients who are mechanically ventilated, especially those with systematic inflammatory response syndrome, such as sepsis, acute lung injury, or RSD. And for Pulmocare, it is indicated in patients who need high calories and low carbohydrate formula that is designed to help patients to reduce their carbon dioxide production and with respiratory issues, especially for patients with chronic obstructive pulmonary disease, cystic fibrosis, or respiratory failure. Nutrien is almost similar to Pulmocare. It is also high in caloric and low in carbohydrate, which can be used for patients with pulmonary diseases, especially those with chronic obstructive pulmonary disease or respiratory failure. The serving size for each of these is almost identical, and it all provide 1.5 kilocalorie per milli. We will be taking a break now for our Isha prayer, and afterward we will continue with COVID-19 and pregnancy. It is not known how to detect intra-body secretion, including the amniotic fluid and breast milk. Effect of COVID-19 on pregnancy, there are no available data to show how it can cause congenital malformation, but some report cases has shown that preterm delivery of women who are infected with COVID-19 can cause vertical transmission from the infected mother to the newborn, as has been shown so far. Instruction for healthcare givers for a pregnant patient who is infected or suspected to be infected with COVID-19. The exposed to an infected patient with coronavirus. First, if the pregnant woman is exposed to infected patient who has coronavirus, the healthcare provider should follow the latest Ministry of Health guidelines concerning COVID-19. In the antenatal phase, the isolation measures, the supportive treatment should be applied following the Ministry of Health coronavirus disease guidelines that were discussed yesterday. And any pregnant woman who was diagnosed with COVID-19 will not attend an antenatal clinic until she is cured from COVID. Also, routine antenatal clinics appointment can be delayed until the patient is cured from COVID-19 and it is not known to cause any fetal congenital anomalies. Serial ultrasound every 4 weeks for fetal anatomy and fetal well-being starting from 24 weeks of gestation is advisable. During delivery, it should occur in an isolation room and the room should be disinfected right after the patient is discharged to the ward following the infection control measures. Also, continuous fetal monitoring during labor is a must done. And normal vaginal delivery with delaying rupture of the membrane is advised for pregnant women with COVID. And cesarean section is for obstetrical reason not needed until indicated otherwise. And operative vaginal delivery is not contraindicated for patients who are positive with COVID-19. And also labor, delivery, and recovery should be done in the same room to minimize the patient transformation. All caregivers in contact with the patient should use protective gears, the minimum to be included, such as face mask with eye shield, gloves, head cover, and disposable gowns as per the infection control policies. And caregivers handling the patient with COVID-19 should change all their clothing, even if they are not wearing protective gowns and head cover, and should wash hands before handling another patient. And routine types of anesthesia and analgesia are not contraindicated. If the newborn babies of a COVID-19 infected mother, they shouldn't be allowed to be in contact with their mother until the mother is cured or declared free of the disease. And isolation of those babies until they are declared clear also from the virus is for 14 days. And if the newborn is tested positive for COVID-19, they should be kept in an isolation until the baby is cured or test negative. And transferring a newborn from the delivery room, they should follow gentle bath with warm water and soap to remove any particles of the virus. Also, placenta should be kept in a container that will be washed before handling to a responsible department and labeled according to the infection control policies. And no relatives should be allowed into the delivery room, and pregnant patients with suspected COVID-19 infection will be dealt with as if they are infected. For ER instruction, a patient with coronavirus or a suspected infection with COVID-19 should be immediately isolated and not sent to the general labor ward until their test result is indicated. And during the patient transfer to the isolation delivery room, precaution measures should be strictly applied, including PPE and following the infection control regulations. And reporting to authorities should be done immediately as per the Ministry of Health Coronavirus Disease 19 guidelines. Also, there are regulations regarding lactation and the potential pharmaceutical therapy. First, paracetamol. In pregnancy, oral paracetamol is considered safe in normal therapeutic doses for a short-term use as a minor analgesic antipyretic in pregnancy. Also, we need to consider administering IV paracetamol to pregnant women only if clearly needed. and carefully assess the maternal benefit and the fetal risk before administering IV paracetamol during labor and delivery. The use of paracetamol during lactation, it is classified as compatible with breastfeeding by the American Academy of Pediatrics and the WHO. While for IV paracetamol, weigh the benefits of breastfeeding with the mother's clinical need and for the treatment with IV paracetamol, and also the potential for adverse effect on the breastfed infant or from the mother underlying clinical diagnosis or condition. Another medication that is used with COVID-19 is hydroxychloroquine. During pregnancy, fetal risk cannot be ruled out, and ocular toxicity have been reported in some cases. So it should be avoided during pregnancy unless absolutely indicated and only after assessing the maternal benefit and the fetal risk. During lactation, there is no adverse effect of hydroxychloroquine in infants who are exposed during lactation. And even though that the benefits of breastfeeding outweigh the risk of the infant, the nursing infant should always be monitored for any adverse effect. For chloroquine medication, during pregnancy, the fetal risk cannot be ruled out, and ocular toxicity has also been reported. And the administered chloroquine during pregnancy is only used if the potential maternal benefit outweighs the potential fetal risk. While during lactation, the American Academy of Pediatrics and the WHO consider it as a compatible during breastfeeding. While the WHO recommend against the use in G6PD deficient infant and advise monitoring the premature infant and the neonates for side effects such as hemolysis and jaundice. And due to the potential for adverse event in the nursing infant, advise the nurse mother to either discontinue the nursing or discontinue chloroquine therapy and considering the clinical benefit of the drug to the mother. For lopinavir during pregnancy, also the fetal risk cannot be ruled out, and avoid the oral solution of this combination product during pregnancy due to the presence of ethanol as an excipient in the solution. And during lactation, also infant risk cannot be ruled out, and advise women that are breastfeeding is not recommended during the lopinavir therapy due to the risk of serious adverse effect to the infant. For guidelines and policies for infant and child feeding, it is preferable to involve the healthcare professionals expert in breastfeeding and lactation. This will ensure that the inclusion of the best evidence and resources of promotion and support, also the protection of the breastfeeding, and to help avoid conflicting messages. Also, multi-sectoral interventions is necessary, so planning and delivering programs of breastfeeding should be developed jointly in both Arabic and English to suit all different tasks. In terms of infection control measures, it should be fully practiced according to the Saudi control and disease guidelines and recommendations that were discussed yesterday. And precaution for lactating women with COVID-19, either suspected or confirmed, regardless of their feeding mode, who must be with their infant, we should follow the following. Practicing respiratory hygiene, including wearing a mask covering the mouth and the nose, especially during feeding or breast expression. Also, they should wash their hands with soap and water for at least 40 seconds before and after touching the baby, the breast expression equipment, and feeding utensils. Also, they should routinely clean and disinfect the surface they have touched and maintain physical distancing from one another for at least 2 meters. This is a figure for the general guidelines for women who are breastfeeding. They should practice, as we said, respiratory hygiene and wear a mask, wash their hands, and routinely clean surfaces. Before preparing or eating food, the caregivers should ensure they practice the recommended hygiene behaviors such as hand washing and regular cleaning and disinfecting of the food preparation areas. And in communities where eating at a commune bowl or feeding children by hand is common, it is preferable to use the child's own plate and spoon to avoid transmission. During quarantine, the history of lactating among the women should be taken and referred for breastfeeding counselors for appropriate support when in quarantine. And during curfew, at a time of curfew and maternal infant separation, all means to facilitate the breast milk delivery should be provided as possible. For non-COVID neonates who are admitted in the NICU, we need to encourage and facilitate visitation of the neonates who are admitted to NICU by their mothers with the application of the recommended screening procedure set by the facility, particularly for direct breastfeeding. And if the admitted nursing mother will not directly breastfeed, then we need to facilitate the delivery of the extra breast milk to NICU with recommended screening procedure set by the facility. Also, we need to optimize the utilization of the feeding expressed breast milk for NICU cases. The extra breast milk delivery difficulties should be solved, such as solutions may include providing hospital delivery services, maternal hospital admission, or providing a nearby accommodation. For the mother and the infant who are suspected or confirmed with COVID-19. First, the mother and her child could be at home or at the quarantine place or even in the hospital, depending on the case situation, which can affect each separately. And there are multiple situations for the mother-infant as summarized below. First, in isolating or rooming in as co-lactation and direct breastfeeding. When the mother are suspected or confirmed with mild, moderate case of COVID-19, the mother and her baby need to stay in the same room with the infant kept in a bassinet and that is 2 meters apart from the mother bed with or without curtains between them. And they should take precautions to avoid spreading the virus to her infant, which include washing hands and wearing a face mask for direct contact with the infant. Also, the infant will be brought to the mother for direct sessions only. Ideally, there should be another healthy adult who cares for the infant in the same room. And in this scenario, one designated caregiver will provide care for both. The rooming in reduces the stress to the mother and can increase the milk ejection reflex. In another situation where isolation and temporary separation between the mother and her infant and breast milk expression. First, when the mother is confirmed with COVID-19, while difficult, temporary separation of the mother and her infant in different rooms can minimize the risk of infection from the maternal respiratory secretion or contact. And mothers who intend to breastfeed or continue breastfeeding should be encouraged to express their milk to establish and maintain milk supply to the infant. A dedicated breast pump should be provided to the mother, and before the expression, mother should practice hand hygiene. And after each pumping session, all parts that come into contact with the breast milk should be thoroughly washed and the should be appropriately disinfected according to the manufacturer instructions. And this expressed breast milk should be fed to the infant by a healthy caregiver. And in this scenario, two designated caregiver will be involved. And psychological support is mandatory for the mother. In the third scenario, which is isolation, separation, and temporary ceased breastfeeding, this can happen when the mother is unwell or extremely sick or even intubated in the ICU, and milk expression is not feasible. We need to perform breast examination for the mother periodically to prevent enlargement of our other breastfeeding complications. Also, separation of lactation may be needed in these cases, and relactation will be resumed once the mother has recovered. We need to refer the mother to lactation support when she improves, and the wet nursing choice is preferred to her infant if the family wishes. In the fourth situation, where lifelong absence of the biological mother, if the mother dies due to COVID-19, the infant will be separated from his mother, and with nursing choice, which start with the expressed breast milk and then shift to a direct breastfeeding when the infant is declared free of the disease, would be the preferred method after family approval. There are multiple options for infant feeding, including first, direct breastfeeding from the biological mother. The second is expressed breast milk from the biological mother. And the third choice is wet nursing, which with the family will be asked to provide a designated wet nurse for the newborn infant to help in both breastfeeding and caring during the mother illness. Also, a social worker should be involved to support the family in this choice. Donor expressed breast milk is another choice from a designated wet nurse, such as home pasteurization of the milk if available, and the social worker should be involved in the case to support the family in their choice. And the final choice is breast milk substitute or milk formula should be chosen as the last choice. Individualized case-by-case approach is preferred method in this guidance for infant feeding. First, the risk of and the benefit of each situation and infant feeding method should be discussed with the mother and the husband by a pediatric consultant. The counseling session include maternal risk, infant risk, availability, caregiver, and latest evidence, local infection control measure, and etc. The family choice should be incorporated into the infant feeding management and given a chance to make a decision. The second one is essential to record the shared action about the mother and the child in the medical care report. And in an emergency situation, the healthcare staff will take the decision on behalf of the family. After the mother recovers from COVID-19, they will resume relactation if it was stopped. And a breastfeeding mother who wishes to practice breastfeeding after cessation section will require skilled breastfeeding support until breastfeeding is re-established. And success will depend on the mother's well-being and motivation and the age of the infant, how long the mother has ceased breastfeeding, and of course, her access to sustained skilled support. For infants who are less than 6 months, they will benefit the most from the lactation. For wet nursing, investigated the cultural accessibility of wet nursing and availability of the wet nurses as a part of early preparedness assessment. Also, wet nursing and relactation can work together in the same time, where the wet nurse can provide supplemental milk until the mother has a sufficient milk production. And prioritizing the wet nurse for the youngest infant is needed. Also, local infant control guidelines of the facility should be respected and considered. For human milk expression, all pregnant and postpartum women should be educated on techniques of milk expression regardless of their COVID-19 status. And the use of breast pump should only be considered when vital. Manual breast pump using an equipment or electric breast pump are all possible choices depending on the mother preference. We need to avoid using pumps that are difficult to clean and to keep the breast milk kit clean and see a breast pump fact sheet below. For feeding the expressed breast milk, each institute should have a protocol for how to handle the mother expressed breast milk, and the protocol should have prior to administering stored breast milk, and it must be checked by two people who are a member of the clinical staff and another staff member or the infant parent by themselves. Also, this could be documented in a special chart. We need also to check the date and the collection of the expressed milk. And we need to check the ID number and the name documented on the container of the breast milk, that it matches the details on the ID bracelet of the baby who is receiving the milk. Also, no milk is to be given to the infant unless it is appropriately labeled and dated. And the administration will be decided by the neonatologist, pediatric, or lactation consultant, depending on the case scenario, such as nasogastric tube, small cup, or syringe or spoon. Also, feeding of expressed milk by a bottle should be used with the caution to selected infant. For psychological support, in the context of panic, lockdown, and concern for family members, this could be highly stressful time for pregnant and lactating mothers. Also, basic psychological support should be a key component for counseling. And the stress of the mother separation can also negatively affect the milk supply and provoke postpartum depression. We need to consider psychosocial support for the healthcare workers and caregiver with COVID-19 should also be provided. For drugs and micronutrient supplementation, as discussed previously, hydroxychloroquine for the mother is compatible with lactation, and azithromycin for the mother is also compatible with lactation, while other antiviral drugs might have an infant risk or no data on it yet. Also, infectious disease specialists and clinical pharmacists should be consulted for COVID-19 cases who are choosing to breastfeed. And as discussed earlier, paracetamol is also compatible with breastfeeding, and the provision of vitamin D should be continued in breastfed infants. And mineral supplementation for breastfeeding mother or bottle-fed infant might need to be individualized according to the general nutritional status of the child. The nutritional guidelines for lactating mother. First, breastfeeding mothers generally need more calories to meet their nutritional needs. An additional of 450 to 500 calories per day of a healthy external food calorie is recommended for well-nourished breastfeeding mother. Also, a healthy, diverse diet is preferred together with drinking plenty of water. And reduced caffeine consumption, such as coffee, soda, energy drink, tea, and chocolate is recommended. In terms of complementary food for the infant, first, simple, practical, and context-specific information are available using all the communication channels of the Ministry of Health to the families on healthy feeding option for younger children in the context of home quarantine and financial barriers. Second, donations, marketing, and promotion of unhealthy complementary food that is high in saturated fat, free sugars, or salt should not be sought or accepted. For breastfeeding, as discussed, COVID-19 can affect mothers who are breastfeeding, and despite the ongoing effort to fight this global pandemic, it is devastating infection with high morbidity and mortality, especially among the adults and elderly population. And even though uncommon, pregnant women and lactating women, the newborns, infant, and young children are not exempt from this infection. And the impact on pregnant women and pediatric cases have so far been reported as less severe than the disease occurring among the older infected people. Programs and services to protect, promote, and support optimal breastfeeding and age-appropriate and safe complementary food and feeding practices should be implemented for young children in the context of COVID-19. Here we will be discussing the available evidence that guides us on breastfeeding in the context of COVID-19. First, mother breast milk is the best nutrition to the newborn. And the main risk for infant of breastfeeding is the close contact with the mother, who is likely to have shared the infection airborne droplets. Also, breastfeeding is not contraindicated at this time. And mothers should be informed about the benefit of breast milk and the risk of the newborn infection with the skin-to-skin contact. If the mother chooses to breastfeed, the mother should perform hand hygiene as discussed and wear a mask during breastfeeding. If an infected mother chooses not to nurse her newborn, she may express breast milk after appropriate hand hygiene, and this could be fed to the infant by other uninfected caregiver. Also, mothers of NICU infants may express breast milk for their infant during any time that their infection status has prohibited and the presence in the NICU is allowed. Also, NICUs should make arrangement to receive this milk from the mother until they are able to enter the unit. And breast pump and components should be thoroughly cleaned in between the pumping session based on the manufacturer guidelines that must include cleaning the pump with a disinfectant wipe and washing the pump attachment with hot soapy water. As we said, direct breastfeeding is not advisable as it increases the risk of direct infection with close contact, and extracted breast milk can be fed to the infant using either a bottle to help with another person. There are precautionary measures that are strictly followed as per the Ministry of Health guidelines, including washing hands, wearing a mask, and using clean breast pump, and cleaning the surface of the milk collection container and to be fed by another person. And if the mother isolation is not required and breast milk or pump extraction is not feasible, then the patient can be allowed to breastfeed with taking in consideration the previous protectionary measures with the addition of a protective sheet between the mother and the baby. Thank you for your time. This will be it for our lecture. I hope you found it useful.